All right, so this is still us, of course, and we will be joined by Sarah Spencer, as you will see, all the way from Alaska. It's always fun when we get to say that. Anyway, so announcements, please turn on your videos if you can. Again, Sarah's joining us from Alaska. I think she'd like to see your faces. These are recorded, as y'all know, and if there's more than one person in your room that could actually use credit, unlike 3 of my 4 children, please chat in who's all there. Coming up, go for it.
We have things coming up. Actually, I'm doing a little one on opioids in the older adult next Tuesday, which is a fun talk. Coming up on the Wednesdays, we have Meth Use Disorder and Bupe by Robert Cole. As you recall, he was the person doing the fellowship for addiction at the U. So he's coming back to give us a great talk.
And then no one can possibly forget November 2nd. Please keep this on your calendar and your radar. Sam Quinone is the author of Dreamland and The Least of Us. Still fangirling over that. We'll be on. The poll we did last week kind of really said that we'd kind of like him to tell his most striking story from all the different aspects of everything, because he kind of went and immersed himself in Mexico for the black tar heroin and all the way throughout. So until anyone tells us otherwise, we'll kind of shoot for that. Try to read the books ahead of that if you can, and tell all your friends.
All right. And remember, if you do need any help, please just get hold of us. You can get hold of Aaron Foss, and all of our cell phone numbers are down there. We get lots of calls, and please feel free to call if you have a question.
And the online center, exciting news. The manual is going to be done sometime before midnight tonight, and it will all get put up on the website. So all the forms, y'all have been asking for the most updated forms, all the updated information you can share for education. It will all be there, as well as how to log in or get information on the different echoes and the case presentation form.
All right. And as we were talking about earlier, the podcast we released today was Heather's third shot yesterday, the third shot at addiction to sugar. And it's a very fun one. And of course, it's not really an addiction, but it is very interesting. So
the 4th edition, I mean, that's how amazing this is. There might be even 5, but the 4th one is going to be on how sugar addiction fits with DSM-5. So
yeah, and I think it's interesting. If we had taken a picture during that, I had powdered sugar all over my face from a bunch of donuts, but that's a whole nother story.
Like your scoop of sugar on the TikTok video.
Yeah.
All right. So with all of our rambling, we would like to introduce Sarah Spencer, Dr. Sarah Spencer, who lives up in Alaska. She's presented for us in the past. I will not at all try to pronounce the names of the towns. And she has kind of been all over lately on all the teaching conferences on this topic, and super awesome. So Sarah, I'll stop sharing and you can share your slides. If there's questions throughout, please chat them in. Kurt and I will try to keep track of that and can help facilitate questions at the end.
And Sarah, you're going to have to tell what the name of this town is you live in, so we know how to say it.
Sure. So I work, I live in Anchor Point, but I work in Ninilchik, and that's the tribe that I'm employed by, the tribal clinic. They're the Ninilchik tribe. And so it's a town of about 800 people. It's about 200 miles from Anchorage, and that is the nearest city that would have like a methadone clinic or another addiction specialist about 200 miles away from us. So, we are on the road system, so we're rural, but we're not really considered remote, in Alaska terms. So I'm going to share today some information about using low threshold access to extended release buprenorphine as a tool to try to increase retention and reduce overdose risk for people who use stimulants and fentanyl together. And the stimulants in our area is pretty much 100% methamphetamine. I don't have any disclosures. I'm employed by the tribe, but I also do consulting work for nonprofit agencies, and I volunteer to help run our local syringe access program. So our learning objectives today, we're going to talk about the epidemiology and the mortality risks associated with comorbid stimulant and opioid use disorders, and the pharmacology of extended release buprenorphine, some strategies to reduce barriers to accessing extended release buprenorphine, and how low threshold access can possibly affect retention and overdose risk in this population of patients. So we all know that we kind of reached this kind of tragic peak in overdose deaths this past year, a 30% increase in the year before, and it is the #1 cause of death in people under age 50. So it's really people in the prime of their lives who are dying. And fentanyl is to blame for a large chunk of these deaths. And we know that pretty much all heroin now has fentanyl in it. But some people really are using just straight fentanyl, like these blue pills are super common, other pressed pills that have fentanyl. So fentanyl use is really ubiquitous now among anyone that has opioid use disorder. And the overdose deaths are increasingly disproportionately affecting minorities, and in our case, Alaska Natives and Native Americans had disproportional increases in their overdose death rates. And Indigenous people also are by far the greatest affected by methamphetamine-related overdose deaths as well. So we know that the use of stimulants with opioids together has been really dramatically increasing in the last 5 years. Essentially nationwide has quadrupled. And when we look at the use of methamphetamine, that varies a lot nationwide. Like there's some places, like kind of traditionally on the East Coast, it's sort of been more cocaine and more methamphetamine on the West Coast, but really a dramatic increase in that use of these two drugs together. And when we look at this dramatic increase in methamphetamine-related overdoses, a lot of people really argue that these are really fentanyl-related overdoses. Over half of these overdoses are really also are related to fentanyl as well. And we know that when you inject methamphetamine with opioids, it's also called goofballing, it's much more dangerous than injecting either of those two drugs alone. It's actually 3 times more likely to result in overdose than injecting opioids alone. So if it's so much more dangerous, why do people do it? That's an important question to ask. And so there's actually a paper published this summer that asked that question. They actually, the best way to find out is to ask the people who are doing it why. And so they interviewed a number of people who are using these drugs together to say, what's the reasoning behind this? And the 3 themes that really came out, one was to prolong the effects of fentanyl. Fentanyl is a very short-acting drug. The effect wears off quickly. And so to try to prolong that effect was felt that using methamphetamine with it would help to prolong the effects. Another was to simply counteract the negative effect. I think was one that we sort of think of logically to reduce the chance that you're going to be nodding out, that kind of thing from the effect of the fentanyl. and to just generally help people to feel better, the enhance your mood and your energy level from the effects of the methamphetamine. So all good reasons why people would want to mix these drugs together. And so you can see sort of why, when there's so much more fentanyl in all the opioids, you can see why people would then want to increasingly want to add methamphetamine to the mix to just, improve their overall experience. So it kind of makes sense why people are increasingly, because there's so much more fentanyl, and why people are increasingly adding stimulants into the mix to improve their experience. So we know that really the single most effective way that we can reduce overdose deaths is with medication that treats opioid use disorder, is dramatically effective in reducing overdose death rates, mortality overall. And but it really only works when we keep people in treatment. If people leave treatment, their overdose death rate goes up dramatically. So it's really important to try to not just get people in treatment, but to retain people in treatment is very important. And a number of studies have come out that kind of shows that I think what we've seen, I think in our personal clinical experience, is that people who use methamphetamine tend to be have poor retention in treatments in MOUD programs, and like in this particular station, it showed that they dropped out at almost twice as quickly from the program as patients who did not use methamphetamines with their opioids. People who did stay in treatment tend to reduce their amphetamine use, but it seems to be more difficult to retain people in treatment. So it's a really important problem that we need to address here is that this particular group of patients they're sort of like one of the highest risks to die from an overdose death, but they're also probably the more difficult to retain into treatment. And I think when we think of why are they difficult to retain to treatment, there's lots of different reasons, some inherent in the disease itself, like in the kind of the chaos that the use of methamphetamine sort of brings into your life, the severity of the substance use disorder, and how difficult that makes it to to do things like to keep up with appointments and that kind of thing, but also the way that traditional medical therapy and our medical system is structured really isn't structured in a way to be accessible to patients who have severe substance use disorders. So a strategy that may help to retain these patients in care for longer is to offer low threshold care, to change our systems of care to make them to better serve this high-risk population. And low threshold harm reduction-based care can be set up in many different ways. There's all kinds of different services that you could potentially offer, and we won't go into detail about all those different things. But really at the heart of it is that this is patient-centered care centered around the patient's goals, and that we're not going to discharge patients for ongoing drug use. We really try to be as flexible as possible to work into some flexibility into our schedule. And we'll talk about with medication injections, if we can have some flexibility, like to even offer walk-in appointments for injections. If we're going to offer behavioral health, trying to offer things that are really accessible, like if it could be co-located or accessible through telemedicine or accessible through apps. And the same thing with peer support. Can it be through texting or through apps? Things that are really more accessible to patients rather than expecting them to go to multiple different appointments on multiple different days. If we can get that patient in there for that one day out of the month, how can we offer them as much services as we can that one time when we have them there in front of us. And in our office, one thing that has helped to get people in the door as a form of sort of as a form of contingency management, just to get them to their appointments, is offering gas cards, because we're in a rural area. So we will give people once a month like a $10 gas card. So that helps them to at least to actually get to their appointment that day. And lots of case management services can help treating their other medical and psychiatric comorbidities, and on-site harm reduction supplies whenever possible. If you can have those to hand out at your clinic, that's always helpful. So some of the, when we talk specifically about extended release buprenorphine and what some of the advantages are to that medication when we're using it in our area, in a rural area, and for a population that has difficulty in accessing treatment. So one advantage is that we don't have any concern about diversion. So and that can be helpful in our area. That's very helpful because there are regions where we're trying to expand treatment. There are regions where it's been difficult to expand treatment because of stigma. So there's can be less stigma associated with this medication. We don't have to worry about diversion if we have patients who are like in a really high risk situation, like they're living with other drug users, they're homeless, they don't really have a way to keep their medication secure. We don't have to worry about that with this medication. And we don't have to worry about, monitoring people, taking their medication correctly. It reduces the risk of withdrawal and relapse related to prescription interruption. So that can be a major problem, both associated kind of with the disease of like the difficulty in keeping frequent appointments that may be required to kind of monitor sublingual buprenorphine therapy. If people can't, are missing their appointments frequently, then they're running out of medications, or they can't get to the pharmacy to get their medications. It's a long drive to the pharmacy. They don't get there, or they're relying on their medication to come in the mail. The mail doesn't come, and so they run out of medications, and then they go through withdrawal and they return to use. The nice thing about extended release buprenorphine is that it doesn't just run out at the end of the month. If patients are late or miss a shot, the levels go down very, very slowly. And so they don't really experience any withdrawal symptoms at that time. And so that is much less likely to be a trigger for them to have cravings and return to use. And it has a very, because it is the highest dose of buprenorphine that is currently available, it has a very, the kind of really the best and longest lasting opioid blockade, especially when we're thinking about fentanyl now. The sort of the difference between fentanyl and heroin, fentanyl has such a high affinity for opioid receptors, and buprenorphine has to really compete with fentanyl. And so if the higher serum drug levels of buprenorphine that we can get, the better it is going to be at blocking that fentanyl. And having it be very long lasting. So if there is a medication interruption, if patients lose access to their medication, they move away, they become incarcerated. Like in our area, they're working on the oil fields, or they're working in the fishing industry. And so they're out for like a couple months at a time. If they lose access to their medication in that way, if they're able to, get a couple shots in to build up their serum drug levels, they're going to have a really long lasting blockade that can last for multiple months to continue to protect them from overdose, even if they have an interruption in their therapy. There have been a couple of these clinical studies that have come out specifically looking at the effectiveness of high-dose buprenorphine in blocking fentanyl-induced respiratory depression. So when we look on this side, this is the control subject who does not have any buprenorphine on board, and this is their ventilation rate. And as they administer continuingly higher doses of fentanyl, essentially the person, their breathing rate slows down to the point where they're becoming apneic. However, when a patient has high dose buprenorphine on board, so this is looking at a patient with 5 nanograms per milliliter, which is what you would see if a patient was on the was stabilized on the high dose 300 milligrams per month of extended release buprenorphine. they essentially are completely protected from that fentanyl-induced respiratory depression, even at high doses. And what they saw, they tested this at multiple different levels, is when they got under the 2 nanogram per milliliter, that effect was really lost, and you started to see the breakthrough in the fentanyl, that the fentanyl was able to induce respiratory depression again. And when we think of, lower buprenorphine doses, when it's like if someone's on 16 milligrams a day, they're going to have times during the day, or if they even miss one dose of buprenorphine, they're going to have times where they definitely drop below 2 nanograms per milliliter. So they're going to be more at risk for that fentanyl breaking through and being able to induce respiratory depression. So when you have patients who are at continued risk for exposure to fentanyl, they're having, some continued drug use, and even if it's not continued opioid use, because we know that other drugs are contaminated with fentanyl. So if they're continuing to use other stimulants or other drugs that could be contaminated with fentanyl, and they're continuing to be at risk for fentanyl exposure, having that high dose, high serum drug levels of buprenorphine is going to help to prevent them from being so much at risk for fentanyl-induced respiratory depression overdose. And this is a closer look at that pharmacology of the really extended blockade that we get, the extended serum drug levels. And this is relying on the patient on getting them loaded up, which takes like 3 to 4 months to get, if we really want to get peak levels. So, and it's really counsel patients that like every month that you come in, your level is going to continue to rise. And so if we look down here, if we can get someone loaded up to on the 300 milligram shot, and then they stop getting the shot, they will have levels above 2 nanograms per milliliter for 5 months after they stop getting that shot. So that's pretty amazing. When we think of people losing access to care, falling out of care, to have that really extended protection from overdose potentially, and from cravings and that sort of thing for that long, basically you're getting, double your money, from the therapy. And also that buys you time to sort of for case management perspective to try to recapture that patient and get them back into treatment. So for any patients who we feel are at risk of falling out of care, we very much try to keep them on the 300 milligram rather than the 100 milligram. As you see, the 100 milligram, you only have 1 extra month. After 2 months, you're going to drop down below that threshold of 2 nanograms per milliliter. So if someone's at risk for falling out of care or at risk for continued exposure to fentanyl, we really try to get them to stay on the high dose 300 milligram injection. So ways in which we can help to reduce the barriers to this medication and make it more accessible. It can be a little bit different than the way that we prescribe sublingual buprenorphine. Is we always give people their injection regardless of their active drug and alcohol use, and this does. The guidelines certainly changed, both the ACM 2020 guidelines, and the FDA guidelines that, we're not supposed to withhold buprenorphine or methadone treatment, related to other sedative use. But, even if patients are, continuing to use other opioids, regardless of what they're using, there's nothing that a patient is using that is going to cause us to withhold this injection, because no matter what they are using, they're going to be safer if they continue to have their buprenorphine on board and continue to have that blockade. If they go off, they're going to go back to using fentanyl again, and their risk of dying is going to go up. So, and we always make sure that patients understand that you're always safe to come in. We're never going to deny you getting your injection, no matter what's going on in your life, no matter what drugs you're using. We want to help you to stop using other drugs or alcohol alcohol when you're ready to stop, but we will never withhold your medication because of other drug use, so that people feel safe with talking with us about that. We also don't require drug testing. Some patients, especially people who have legal issues going on, they just don't feel comfortable in giving a drug test. They don't want that to be like a paper record trail of that in case their records got subpoenaed or something by the court, and they just don't want to give a drug test. And so the nice thing about this is that we don't have to require that. You know, a lot of times they'll still verbally tell us, yes, I'm still using methamphetamine every day. You know, yes, yes, I tried, using fentanyl a couple times this month and it was pretty much blocked, whatever. But they don't have to give us that sample because we don't need to know it for medication compliance reasons. We're not worried about diversion. We're not worried about whether they're taking their medication or not, which is one of the main reasons that we're doing the drug testing. So we don't have to require them to do drug testing for this. Flexibility in the schedule, again, whenever possible, especially when we're having patients who, we try to get them on a schedule where they're coming in every 4 weeks and try to get express the importance of really maintaining that schedule so that they maintain their drug levels and try to keep them, in recovery in that way. But when we have patients that really struggle with that and, it's been 2 months since they had their injection and they call and they missed, a couple of their appointments and they say, hey, I'm in town today. Can I just stop in this afternoon? We try whenever possible to just squeeze them in for walk-in appointments for those injections. We also do off-label medication starts for patients who have current opioid tolerance and previous experience with buprenorphine. So the package insert instructions for starting extended release buprenorphine says that you need to have a patient on sublingual buprenorphine for a week prior. But if you have a patient who already currently has an active opioid tolerance, especially a high active opioid tolerance, like they're using fentanyl, and we know that they've taken buprenorphine in the past and they've done well on it, they like it. All we really need to worry about is that we're not going to cause precipitated withdrawal when we give the injection. So we basically only require people to have taken a single dose of buprenorphine before they get their injection. And I have even given it to patients who did not take their dose of buprenorphine before they came in, but they've had, at least 12 hours since they've used, if they failed like multiple times to induce, if they, we have a whole conversation with informed consent about what precipitated withdrawal is, about how to treat it. We make sure that they have strips, or tablets of buprenorphine on sublingual buprenorphine on hand so that if they do experience precipitated withdrawal, that they are able to treat that. The best treatment of precipitated withdrawal is to immediately take 16 milligrams of buprenorphine and then repeat that with 8 to 16 milligrams up to 32 in that first day. The fact is that precipitated withdrawal is uncomfortable, but at least with this is that they're going to be, it sucks to be sick for 4 hours, but after that, they're going to be completely protected for the next month. And in theory, never going to have to experience withdrawal again if they stay on the injection. So many patients feel that that is worth the risk. And we have that whole conversation about what that might feel like, what the risk and benefits are. So if we have patients that just really struggle, they try and try and try again, and they just can't get on it because they just are so scared or whatever, or they just struggle so much to take those doses of sublingual buprenorphine, there's such high risk for overdose that sometimes those benefits really outweigh any risks that might be associated with the precipitated withdrawal. Flexibility in the dose, again, to allow patients to kind of go up and down between the 100 and the 300, depending on, whether they're experiencing side effects, what their risk factors are. Most of our patients in this category who are using methamphetamines with opioids, we really try to encourage them to stay on the 300 milligrams. So they have a better blockade. And so if they fall in care, they'll be better protected. And making sure that the end of the first month, that people have access to supplemental sublingual dosing. It's really important to remember that at the end of the first month of extended release buprenorphine, those serum drug levels drop down to what the equivalent would be, they drop down below that 2 nanogram per milliliter level. Like they drop down to what would be the equivalent of like a 12 milligram buprenorphine dose. And that is not a full blockade of fentanyl. And so if people are having cravings at the end of that month and they are using, they're not going to be fully protected. And so it's totally normal for people to have breakthrough cravings at the end of the month. And it is totally okay to give them supplemental sublingual supplementation at the end of that month. So we make sure that patients at the beginning, and also the patients are aware that that's normal. The first month is normal because you only have the one shot in your body. Afterwards, as you get more shots, they add together and your levels go up. And so each month you're going to start feeling better and better as your levels go up. So we make sure that people understand that first month is going to be a little rocky and every month is going to feel better. So that people have realistic expectations about what it's going to feel like, and that they're not, that they're not frustrated by the way they feel at the end of the first month. And we do offer this to very high-risk patients in their second and third trimester of pregnancy. We don't have, and again, this is a risk-benefit conversation with patients. We don't have any data in pregnancy. We do know that there is the potential in animal studies for teratogenicity in rats, and it's not because of the buprenorphine, but because of a component in the gel. So we haven't seen any data in this in humans yet. We know that in pregnancy, the largest risk of teratogenicity for sure is in the first trimester. And so when patients are kind of out of that range, when they're really high risk, like they just have not been able to stick with taking their sublingual buprenorphine, they haven't been able to stay in care, then it probably is less risky for them to make that transition to extended release buprenorphine. But it is important, for patients to know that if they're already on extended release buprenorphine, that's important to be on contraception, because once you get pregnant, you can't take it out of your system. Again, remember how long it stays in your system, it's going to be in there. So it's important for patients to understand if they are not on contraception or if they stop their contraception and they do get pregnant, that there may be a risk of birth defects in that first trimester. We just don't know is what it comes down to. And this medication has a very high patient satisfaction rating. And I really share this with patients. Now that we have done so much of it for like the last 4.5 years in our clinic, almost all of our patients come to us self-referred because their friends say, this is a great medication. And they self-refer because their friends told them to come see us. But patients who haven't heard of it before, or they've only had experience with sublingual buprenorphine, sometimes they can be really apprehensive about making this change to the extended release form. But studies, a number of studies that have looked at this have shown that patients, who have been on sublingual and make the switch to extended release buprenorphine, over 80% of them actually prefer the extended release to the sublingual. So very high patient satisfaction. The things we hear from patients that they just love that they wake up feeling normal every day and they don't have to take something every day. They love that they never experience withdrawal, that when it wears off, they don't feel it wearing off, and that they get, that adequate blockade. But, the one thing I do warn patients about is that you don't feel it wearing off. Like that also can be a dangerous thing in this patient population. So I always warn people about that right up front. Say, that's what everyone loves about this, is that you never experience withdrawal symptoms if you miss your shot. But it's really important to understand that even though you don't feel it wearing off, it is wearing off. And it might take a couple months. It might take 3 or 4 months if you've gotten a lot of shots, but it is wearing off. You don't feel it wearing off. You don't realize it's worn off until 3 or 4 months later, your friend offers you something. You didn't even realize you wanted it until something stressful happens. You use something and then you realize, you don't have that blockade anymore. You can get high, or worst case scenario, you don't have any opioid tolerance anymore and you have an overdose. So it's really important for patients to understand that up front. So just some data to share from our little rural clinic here that we have been sharing at a couple of the national conferences here. We went through and reviewed our clinical data from our prescription drug monitoring reports and our EMR of our patient populations in our OBOT program who who use methamphetamine with opioids. And we looked at kind of comparing the patients who were taking only sublingual buprenorphine compared to the patients who had received at least one extended release buprenorphine shot. Some patients had gotten many shots, some patients had only gotten one, but patients who had gotten at least one injection, and kind of comparing these two groups to see what their total cumulative weeks of buprenorphine therapy was. And there, for a lot of patients, there was kind of interruptions in their therapy. They were kind of on and off, but just adding up what their total cumulative weeks of buprenorphine was. And we also looked at to see kind of before we started offering extended release buprenorphine and after we started offering extended release buprenorphine, did our retention and treatment change on the sublingual buprenorphine? And it did not. So it was slightly increased, but there was not any statistically significant change. So essentially, people, were still staying on sublingual buprenorphine the same amount of time before and after we started offering extended release buprenorphine. And in our practice, like nationwide, we have seen a dramatic increase in patients being admitted to our program who are using methamphetamine with opioids. So 5 to 6 years ago, only about a quarter of our patients coming in were using these two drugs together. And now the vast majority, over 75%, and I think it's even higher this year, of patients who are using these two drugs together. So most of our patients are now. So when we looked at these two groups together, it was about 55 patients. The patients who were on the sublingual buprenorphine accumulated about 18 weeks of buprenorphine therapy versus the patients who were on the extended release buprenorphine accumulated about 31 weeks of buprenorphine. So that's about 3 months longer of therapy. And when you think of how from the pharmacokinetic standpoint of this medication, that's actually really significantly longer than just that. Because when you think of really each shot that you get, you're getting almost, for every month of a shot you're getting almost 2 months worth of therapy, and again, that depends on stacking the shots up. It depends on whether you stabilize or not. But you're getting much more bang for your buck in terms of actual length of time that you're getting therapeutic levels. But in terms of just simply the weeks of therapy, they were really were able to be retained in treatment for significantly longer. And when we looked at the percentage of patients that were able to accumulate 24 weeks of therapy, that was almost doubled in the extended release buprenorphine. So about 6 months of therapy or 6 shots. That was about 61% of the patients in the extended release group. So almost double versus sublingual group. And very few people got to the 12 shots or, close to a year, 48 weeks. But that was almost triple the number. So very small number of patients that we're looking at. These numbers are super small in our rural practice, but they were all statistically significant despite their small numbers. So general summary and takeaways, patients who use methamphetamines with fentanyl, they're at increased risk of overdose death, and they also have a lot of barriers to accessing care and retaining in treatment. Extended release buprenorphine has a really high patient satisfaction rating and a unique pharmacology that helps to block fentanyl-induced respiratory depression. And it also, the blockade can extend beyond the cessation of medication. And this can help to reduce overdose risk group in this particular high group risk group. And if we offer harm reduction-based low threshold access to extended release buprenorphine, it may help this high-risk group of patients stay on buprenorphine longer. And so treatment programs should really work to reduce barriers to access for this medication. So I'm going to end there, and feel free to reach out to me if you have more questions or want to talk in the future. And I will stop sharing here.
All right. That was fabulous. I was going to ask a question right away.
You can go over it.
Okay. So there was a question, and actually I had just written down the same question. It's like, often when we go to that 300, we have a little trouble. How much trouble are you having with insurance companies when you get the high-risk patients?
So I don't, so, well, our state of Alaska Medicaid, most of our patients have Medicaid. And the state of Alaska Medicaid, there is no prior authorization. They don't care which you use. And I'm surprised that any insurance company cares, because it's the same price for both injections. And so, is my understanding, and the labeling and the packaging says that you can go back and forth depending on how patients are doing. So I've never had any problem with insurance and going back and forth. But I would say, over 80% of my patients are on Medicaid, which is, for us, it's the simplest to order through. Private insurances are all kind of hit and miss as far as the, what the prior authorization hurdles that they kind of put you through. Usually once we get the initial prior auth done, it's easy, and we don't, have any issues with going back and forth. But I think that it says right in the prescribing instructions that you should, go up if a patient is experiencing cravings. So I think just sort of like cutting and pasting and saying, it says right in the prescribing instructions, you're supposed to do this. So I think there's, hopefully that's not a problem for people, but I haven't had that problem myself.
Okay, so with the co-injection thing, so back to the beginning when you talked about any mention, the things that people say why they co-inject, was there any specific mention of, it talked about preventing some of the negative impact, negative effects of the fentanyl, like fading out? Did they ever say that, maybe not appropriately, but that to prevent overdose? Like, oh, if I take this with this, I'm not going to overdose and die. Did they ever mention it like that?
I don't remember seeing that in that article. Yeah, that article that was interviews. I think it was done out of Canada. That article that was the interviews of patients. I think they had interviewed like 30 or 40 patients or something. And I don't remember that being cited as a reason that patients had cited. I think that we think, and I haven't heard patients say that recently, but I think in the past, previously, that was a worry, is that patients, were injecting that as thinking, oh, this is going to keep me awake, or it's going to reduce my overdose risk, because, adding a stimulant in is going to, it's going to make me less likely to overdose, right? Because I'm negating the effects of the fentanyl, which is unfortunately, because of the sort of the cardiovascular negative effects of the stimulants. Those negative effects is what, harmful effects is what increases the overdose risk, because, it just doesn't, despite the fact that it is stimulating, it just is not stimulating enough in any way to overpower the massive respiratory suppression effects of fentanyl. It just doesn't. And so you still have the massive respiratory effects, suppression of fentanyl. And then on top, you have the harmful cardiovascular effects of the stimulant. Which is why, we have the arrhythmias and all those other sorts of things that go along with that. So, which is why we have.
We've just heard it so much as this is going to help me in my withdrawal. So I'm just curious if you heard anything about prevent my overdose death.
Yeah, I haven't heard that, but I think I haven't heard patients say that, but I've always worried that people think that.
Sarah, don't you think you could almost make a case for routinely, if you have somebody that's using any methamphetamine, that you go to the 300, just because there's so much fentanyl in the meth?
Mm-hmm. Yeah, I try to convince everyone who is using those two drugs together, or who continues the use, to stay on it. And I talk with them specifically about that. If they're thinking of coming down, like if they're like, maybe they're a little bit tired the first month or so, and, like, oh, this bump is kind of big. Maybe I want, the smaller bump. I really try to convince them to stay on the higher. And the vast majority of my patients are happy to stay on the higher dose and they like it. But I definitely try to, really actively encourage my patients who are continuing to use drugs to stay on the 300 routinely. And I really only, sort of encourage anyone to go down or offer them to go down. If they're doing well, their cravings are controlled and they stop the use of other drugs.
Yeah. I have a patient who just got his first 300 and then came back for a second one, and a lot of the fatigue, a lot of headaches, but he's been on Suboxone for years. So we just went down, but he's like super low risk.
Yeah.
Here's another thought with that whole, the data you showed with treatment retention with meth versus patients who don't have meth. I just can't help but think, and I'm assuming it's the same where you are, but maybe not, is that a lot of, whether it's even clinical providers even, is that if people are still using meth, then they cut them off their Suboxone, or they kick them out of treatment because they still have other substances. So versus that whole harm reduction. And so if some of that treatment retention isn't caused by the treatment facility or provider, not necessarily the patient.
Yeah. That was one of the reasons, that we looked at like our sublingual retention to make sure that didn't change before and after. And it actually went up a little bit, but it wasn't statistically significant, that we didn't change, the way that we prescribe sublingual, after we had the extended release, being offered. But yeah, I think that, people are hesitant to, I think people are just with sublingual buprenorphine. I think people are hesitant to continue to prescribe it for patients who are continuing to use other drugs. I think people worry a lot about diversion in that group of patients. And so it can be really difficult for patients to access, and like there have been, and there definitely have been, there was a meta-analysis study looking at patients' access to treatment who use methamphetamines with opioids, and it's way lower than it should be. And I think that's one of the reasons is that people just are really hesitant to continue to prescribe to sublingual therapy to patients who, continue to use methamphetamines. I think really the issue is just the worry about diversion and the increased work and maybe having to monitor for that. And that feeling that you have to continue to like give them short prescriptions. And then that makes it really difficult for the patient, right? If the patient's already struggling to keep their appointments and you're like, I still want to see you every week, then that really makes it continually difficult for the patient to keep up with that for a long period of time. And so then they end up falling out of care because they can't keep up with that frequent schedule. So there's just like so many challenges on both sides with that.
Really quickly, and then I'll get to this last question, or the questions that just came up. With the whole pregnancy thing and the first trimester thing and encouraging contraception, do you have like where you say, okay, if you're wanting to conceive, people want to, do you say we need to kind of go back to the sublingual at this point? Is it that 5-month mark? Is it 3 months? Like when do you recommend going back to the sublingual?
Yeah, so it would depend, it would depend on the dose they're on. So you can kind of look at, that graph. That's from an article on like the pharmacology of, it's a really good article if you want to learn more about like the pharmacology of extended release buprenorphine. But you can kind of get a sense for like where the levels drop down and really like, because we have no idea really, because we have no data on, whether this is an issue or not an issue in the first trimester of pregnancy, but having that informed consent with the patient, like if you were planning it, to consider like that, we know it takes this long to come out, depending on like if you're on the 100, let's like look at this chart together and, see, how many months until like most of this is going to be out of your system and kind of, just having that informed consent conversation with the patient. How long are they willing to wait? What's reasonable in their lives? Like how much risk are they willing to take on? And we don't even know if there is a risk or what the risk is. So it's all this really theoretical conversation, but that, if they, desire pregnancy and they're on, the extended release buprenorphine, that I think that it makes sense to make that switch to sublingual, and, waiting, 3 to 6 months, depending if they're on the high to low dose, and just having that conversation with them that just to be on the safe side, that probably makes sense to do that.
All right. Yeah, we haven't done it in pregnancy yet. So question about anyone in general, whether it's you, Sarah, or anybody else, about specific policies, procedures for MAT and Sublocade. So we have several. We do. Our clinic has like an induction policy that has Sublocade. I haven't looked at it yet, to be honest with you. Does anyone have anything they've put together that would include something like this? Or Sarah, do you all have something like that?
We don't have we don't have a specific policy for Sublocade. We have different tracks, like in our medication agreements with our patients, that talk about the different levels of monitoring or frequency of visits and things are requirements for sublingual versus extended release, sort of like the normal track versus the slow threshold track, so that patients can know what is expected to them if they make a choice, for one versus the other. But we don't have our clinic, our clinic is super small. And so we don't have specific written policies for it. But I think if you're going to write policies, I think it is really important so that you have that consistency between providers. I think it is really important to have things specifically written out, like you're not going to withhold it for other drug use, that you're not going to require a drug test, things like that, because you really have to think of, is it really going to change your therapy? And is it really in the best interest of reducing, mortality in that patient? Like, why are you doing what you're doing? And that this is a very different, medication in terms of risk of diversion, things like that, than sublingual therapy. Like, why do we do what we do? And what are you going to do with that information? And the policies and procedures, should be really, most of the issues around policies and procedures for this medication are, related to how make sure that how to store it properly and keep records of it properly, and knowing how to order it and all that sort of thing, knowing how to dispose of it. That's actually most of the policies and procedures related to this particular medication. And otherwise, just making sure that people understand and are all on the same page with how to start people on the medication. And when people are, and some of that, again, it's clinical judgment, but that people, have training and understanding the nuances of that. And when people have, missed an injection and it's been a certain length of time, how do you know when you need to offer sublingual therapy again before starting it? But other than that, the policies are actually much less, far fewer than you need. It's much more simple than what you need with the sublingual therapy. A lot of it is really around the meeting the requirements, which aren't very complicated. It's really pretty straightforward for the ordering, storing, record keeping, and disposal it's pretty straightforward.
Sure. And yeah, we actually just updated and changed all of our consent forms to kind of include more of that patient-centered, almost low threshold, but without the name low threshold kind of aspect to that. So, and that'll be all on the website soon. So, other questions?
Anybody else?
I've got one. Mm-hmm. So in the, 3 years I've been doing this, I have noticed that a ton of patients seem to have either undiagnosed or untreated ADD. And so I've started a bunch of people on Adderall. I'm wondering, have you looked at the people that are using the meth in Alaska and do they have undiagnosed EDD? Because meth will treat it.
Yeah, I think, a lot of patients, a lot of my patients specifically will come saying that they've had it in the past, or you can tell just by talking with them, that they probably do. I don't offer people amphetamines first line if they have a substance use disorder. I do occasionally, if they've been, diagnosed, by a psychiatrist or seen with them, they've had like a lifelong history of it. They've done well on stimulants in the past. I don't do that. I do non-stimulants for adults first line, like Strattera and things like that first line. But if I have a patient who, they've done really well on it in the past, they have a job or they're actively looking for a job and they have done well in stimulants in the past and they are willing to do the monitoring required, like we do directly observed therapy for high-risk patients with high-risk medications to make sure they're taking it correctly, because we certainly worry about misuse of amphetamines in a patient with an amphetamine use disorder. So it's not that, because we know that stimulants can be very effective in patients who have ADD. But in adults, we also know that the non-stimulant therapies in adults can also be effective. And so with patients with a stimulant use disorder specifically, or substance use disorder, we like to try the non-stimulant therapies first. And we like to get them engaged if we have psychiatry available to do an actual assessment. We like to have that done to make sure that they have an accurate diagnosis, because we want to avoid patients misusing those medications, and I don't want to give those medications to people who aren't actively looking for a job or actively working. Like if they're just sitting at home all day, like they don't need to be taking Adderall, right? So and having the risk of diverting or misusing that. So for a certain subgroup of people, but it's definitely the minority of patients. I would say like a lot of my patients who use amphetamines come in and ask for a prescription for amphetamines, but it's the tiny minority that I would actually prescribe them in. But yeah, I think that yeah.
Sorry, Kurt.
Oh, I was just going to say, there was a study that's somewhere in our file about, people that truly had ADHD or ADD and were put on, after a certain period of time, put on stimulants, and they're actually much more likely to have a job, own a car and a house. But I think, we've all been burned or had patients where it went the wrong way. But I've certainly had some great success stories in patients who had clearly documented ADD in high school and had the full eval. It's always a little scary for me as well, Sarah. And I think that I think Heather and I, we talk about this all the time. But go ahead, Heather. You had something as well.
So one thing, just anecdotally, that especially came out of working in the jails when it came to this question with, are they just treating their own ADHD? Is asking them like, what happened? I always ask a patient who uses meth, like, how does it make you feel? And when they answer, I can focus, I can work, I can, read a book, those kind of things. I mean, in my head, I'm like, okay, this person probably has some type of attention issue. But then my next question always follows up is like, let's talk about your ACE score. Because I find that a lot of patients, I think a vast majority of patients, and Kurt loves when I have this conversation, a vast majority of patients who use methamphetamines have a lot of PTSD, trauma, chronic PTSD. And so treating it from that perspective, like let's really work through your trauma, let's kind of address it that way, has definitely been positive without needing to throw stimulants on top. But yes, of course, I do have a few on stimulants with the same kind of thing. Like Sarah said, they're working, they need it for real to function at their job.
Yeah, that being said, we've all probably had a patient come in and say, why can't I be on Adderall so I don't take meth? And those studies have been done, and the biggest one probably in Australia. And initially they came out and said, oh yeah, Adderall actually works kind of like a Suboxone for methamphetamine. But when they reworked all that data, it was clearly not the case. And they did they did worse. And so I have patients ask me that all the time. Why can't I? So Sarah, you were going to say?
Oh, and I was going to say, technically that would not be legal.
Correct.
I mean, from a standpoint of like treating an addiction with the substance outside of using buprenorphine for, right, because there's specific law against that. But of course, you're prescribing it for ADD, that's different. But treating an amphetamine use disorder with amphetamines technically is not legal because it's not FDA approved for that. purpose, and there's a law against,
Yeah.
using drugs in that way.
Yeah.
All right. Anybody else? Any other thoughts or questions?
Great questions.
What's the process for being able to start using subluxury? Are there hoops you got to jump through?
No, there really is not there. So if you're ordering directly for an individual patient from the specialty pharmacy, and you're ordering it as the patient's own medication, the specialty pharmacy bills their insurance. Like for us, it's Medicaid usually, and it comes delivered to your office as the patient's own medication. You don't need to do like any REMS certification or anything for that. There's nothing you don't need to be certified. There's nothing you need to do. You don't need to sign up for anything. Basically, you just choose. You can go onto the company's website. They have a list. You can see which specialty pharmacies will deliver to your state. There's like more than a dozen specialty pharmacies now, and then you fax we use Magellan in Orlando. They're very user friendly, and they shipped us in Alaska like within a couple of days. So we fax the prescription to the pharmacy. Then we have to call them to arrange the shipping, and we pay the copays because it's like a $3 copay. And if we don't, then they're trying to contact the patient. It never gets paid. It never gets sent. So we have an arrangement with the pharmacy that like quarterly we pay all the copays. And they ship, we have to call them to verify the shipping. And then that same day, the next day, it's like overnight FedEx shipping. They ship it right to our office. And then you need to just understand the requirements for storage, which is a locked box in a locked fridge in a locked room. And you need to have an ins and outs sheet where you keep track of, when it comes in, when it goes out, and kind of understand how long you're able to keep it there before you need to dispose of it.
Perfect. All right, everybody. I think we're past our time. Actually, Sarah, that was fabulous. That was just a wonderful, wonderful talk on Sublocade. I think everybody would agree with me that I learned a lot. I mean, that was just fabulous. So thank you so much.